Um, so this concerns a fellow who's probably in his 60s, I think. I'm not sure if it shows their age, 64, yeah. Um, who I met last fall, um, where his complaint was like leg weakness. He had a spinal stenosis history, and I kind of pursued that. First, he clearly had some cognitive slowing and kind of relied on his sister to provide some history. Our staff, who had known him before I came to the community, thought he had an alcohol use background, but he denied current use. And so for most of the past year, we've been trying to figure out his neurological symptoms, both the kind of peripheral gait and weakness issue, and then also it took several times seeing him before I got a sense of where his cognition fell. I think he was, chronically undertreated or non-adherent for hyperlipidemia and hypertension at the least, and is a lifetime smoker. So ultimately, my sense has been that he's got more of a vascular dementia process underlying. It was really not until just kind of screening labs, Medicare catching up on quality measures, that we did a Hep C screening. I don't know, a couple months ago now, and that was positive, and the RNA came back too. Um, no, other than just kind of his age range, there's no clear history to me of what his, kind of historic exposure to it. No injection use as I'm aware, or tattoos or past transfusions that he could recall. But in the workup, the main couple of things, the key question, I just want to check my thinking from past conversations, is that his I think his Hep B surface antibody and a Hep B core antibody came back positive. We've had some issues with our local labs. I'm not sure if those are all I ordered initially, or if some one of the machines at LabCorp that serves us has not been working. So I forget whether I got um, like a core antigen, say. But my main question is whether in the context of Hep B, both surface and core antibody positivity, if I need to uh, worry anymore about that, or if the positive surface antibody tells me, hey, he has immunity to Hep B now, and we can go ahead with Hep C treatment. I don't think I'd had the genotype had come back yet when I submitted this, but it came back as genotype 3, and I also just wanted to make sure that Mavorette was okay for that, which was my understanding of it, but wanted to be sure. And then in a broader sense, I was just kind of curious from anybody's experience, if any, you know, okay, so he's non-cirrhotic. I think what did we? Yeah, his serum, his fibrosis had him in a pretty low chronic liver um, tier. Let me see if I can pull it up. So anyway, I'm just curious whether Hep C absent, cirrhosis with hepatic encephalopathy is something that anyone's ever seen that could maybe account for this, this guy's dementia. I never met, like I said, met him a little over a year ago, um, and our staff here said, like, no, he used to be a pretty simple guy, but fully cognitive in his past interaction. So just any thoughts about that possible association?
Thank you so very much. Really appreciate it. And the time you took to do that for us. Thank you very much. Anybody else have any questions or comments?
Oh, and so I would add, yeah, besides the CNS, kind of the cognitive dementia aspect, his through the year, where the spinal stenosis, was seen again by neurosurgery, and they said, we really don't think this is the cause of his gait issue. He did see neurology. I think there's someone down at UHC who's not fully integrated into Epic, so we get the notes like 5 months later. But they did nerve testing and called him a CIDP, I guess, and gave him some IVIG, and that kind of stabilized the gait and motor decline, and it's like very, very gradually improved. So I guess even more than the dementia aspect, the peripheral, inflammatory neuropathy, that would, if there's any kind of link to Hep C, that would be particularly interesting to know about also.
Thank you. Go ahead and.
All right, we unmuted. We're unmuted. Big picture take on this guy, Quentin, is you'll never know to what degree his comorbidities could have relation to Hep C until you treat him and see what gets better. My compliments for catching a guy without any exposure history and just a classic reason to screen. I don't want anything I'm about to say have any misgivings that this was prior knowledge. This came purely as inspired by your case and your questions, brother. So good job. So when I go to the PubMed and look it up, there's absolutely associations between CIDP and amyloid and Hep C. There's some cases of improvement with treatment and so on and so forth. But mechanistically, stepping back, why would we even be suspicious of? In big picture, CIDP representing an autoimmune disease. So remember, one of the things we always talk about with extrahepatic manifestations is the various mechanisms whereby you can have extrahepatic manifestations, and autoimmunity being one of the major ways that we get symptoms, extrahepatic manifestations. Again, you're dealing with chronic immune activation. The body has a chronic incurable viral infection, and it gets angry, and it activates things, including B cells that make antibodies, and some of those antibodies are maldirected, hence the potential CIDP. I'm no amyloid expert. I just know it does represent chronic inflammation. It said the most common form of amyloid. Again, amyloid, for those of you like me, it's sort of a nebulous process, represents malfolded proteins depositing in various parts of the body, including kidney, heart, brain. The most common form of amyloid being immune system proteins, and coming from aberrant B cell clones. Remember, the pathophys of Hep C, gone untreated long enough, it causes B cell clone activation that can eventually convert to a monoclonal gammopathy and even a non-Hodgkin's lymphoma. So purely from everything we know about Hep B, you would say, yes, that chronic inflammation very likely could cause a secondary amyloidosis. Clearly, a CIDP makes sense. It fits into the category of things you can improve. Quentin, you asked an awesome question. Can you get extrahepatic manifestations in a patient that's non-cirrhotic? And the answer is absolutely. So one of the dangers of only focusing on liver health with hepatitis C is forgetting the fact that this is a chronic systemic viremia, and it causes problems throughout the entire body. So yeah, while his liver may be not taking the brunt of the insults from Hep C, perhaps his chronic inflammation is more dangerous in this particular guy. Now, Kaylee and I were sitting here talking, and we have a hard time buying a guy that has had this for so long. It's genotype 3, doesn't have more damage. His CBC looks good, his fiber sure looks good, but I'd get some imaging on him, man. I'd definitely get some imaging if possible. Obviously, we always prefer elastography if you can, but at a minimum, getting an ultrasound or some other modality that's making sure he doesn't have that classic cirrhotic morphology or anything else to suggest advanced liver disease, because the genotype 3 is just suspicious from that end. If you do treat him, Mavorite or Epclusa are your only genotype 3 options. Probably prefer Mavorite, and you probably have to hold your atorvastatin while he's on it. Oh, Rachel's here. Never mind. I'll stop talking about drug interaction. But that's my, again, generic approach is if I see something in somebody's history and it has potentially immune activation underlying it, I promise you there's a potential link between that and Hep C. So whether it's causal association or unproven, it passes the logic test. So yet one more reason to treat the patient.
Hey all, and from a drug interaction standpoint, like Dr. Gilfus already said, that atorvastatin is going to be the biggest issue. So you do have the option, if you're going to go with the Mavorite, to hold it just for the treatment duration. Mavorite doesn't stay in the system for too long, so you should be able to just go ahead and restart that once he's done. But if he's able to just not take it for that 8-week treatment duration, you could change it to another agent if you're concerned from the cardiovascular history of holding the cholesterol med. So you've got options. You could change it to rosuvastatin, max dose of 10 milligrams, or you could change it to something like a fluvastatin or pitavastatin. Both of those are options as well. Technically could also do pravastatin 20. So you do have those options if you would want to change to something else and not just hold the atorvastatin for that 8 weeks. If you would go with Epclusa, just because that is one of our other more common ones and available on most formularies, the rest of those, they have interactions with all the statins. With the atorvastatin, though, it's just one of those generic monitor. So usually we just educate the patients on the signs and symptoms, myalgias, and those sort of things that you see with statin toxicity due to that increased concentration. So we can just monitor. There's no, prior to start date dose lowering or anything like that with the Epclusa. So you do have those options there, but no concerns with the other, the amlodipine, the aspirin, as far as the Hep C treatments go.
Hey, Quentin, one more thing, and then Kaylee has a comment on the genotype 3. The time frame I saw in that one case report for improvement for the CIDP case was about a year. So remember, it takes a long time to turn an immune system response off. So don't despair if things don't get better quickly.
And then Quentin, the two comments I wanted to make were about the Hep B serology that you'd mentioned, and if that's going to have any impact. So just make sure, from what I recall you saying, you had the positive or reactive Hep B core and then a positive Hep B surface antibody. Just with those two alone, I wouldn't worry about any type of reactivation with the Hep C starting into any direct acting antivirals. Even if you have those two, you wouldn't expect a Hep B surface antigen to also be positive. It wouldn't make sense that he'd have active Hep B plus protective immunity, but you'd still want to make sure you grab that marker. If he happens to have isolated core Hep B positivity, so no protective surface antibody, then you would worry a little bit about the potential for Hep B flare, about 2% risk with the isolated Hep B core, and that's whether or not he would have cirrhosis. And then the only other quick comment I wanted to make was, we do have the two pangenotypics, so the Epclusa and the Mavorite. In his case, I would probably, just to be most prudent, go with the Mavorite for 8 weeks, and that's just because that potential, even if his fibro test doesn't show any worry for cirrhosis, if his imaging does, and you have genotype 3, remember there's that polymorphism that goes along with genotype 3 and cirrhosis, that if it's present, the Y93H polymorphism, it can really significantly reduce the ability to achieve sustained virologic response. So I actually wouldn't choose Epclusa with that being present. I tend to favor Mavorite with genotype 3 and cirrhosis. So that's just on the off chance that that is the case.
Thank you very much. You guys are so great. Quentin, do you have any other questions?
No, that's like super helpful and covers a lot of what I was thinking about. Just to wrap up the takeaways. So Hep B core antigen is still worth checking, even though we expect it to be negative, and liver imaging with elastography if we can get it.
Great. Thank you very much. All right. Appreciate it. All right, Jennifer, are you ready for your 2 cases now?
Oh gosh, ready as I'll ever be. I'm sorry I was late, and I'm sorry I missed most of Quentin's case. I'll have to look at the recording. That sounded really informative.
No
Hey,
worries.
Elizabeth, as you're bringing up, can you bring up the female first? Is that possible?
Yeah, of course. Give me one moment.
Should,
All right. Yeah, the 37-year-old female case ID.
yeah, she'll be a little quicker. So these, Okay, let me get my head in this right place here. So these are the two case that I'm going to present. They are a couple, and I saw them last week. The first person is a 37-year-old Caucasian female with Medicaid insurance. She got diagnosed with Hep C in 2020, but saw a GI at that time who told her that her fibrosis score was not high enough to treat. So she was recently referred to me by one of my colleagues here at New River. Her risk factors were IV and intranasal drug use, intranasal starting at age 13, IV age 17. For about a year, she had some non-professional tattoos at age 16, starting at age 16. Actually, she said, when I asked her about tattoos, she said, I'm covered in them. And so anyway, she has been sober from drugs for about 5 years. She has been drinking, it was a very sad story. She's been drinking alcohol 3 shots a day since she lost a newborn infant, actually, yeah, newborn of a year ago. She says that she can quit. She's been in counseling and is on antidepressant medication. So I, talked to her about the hazards of using alcohol for her liver. They are currently only using condoms for contraception, and they'd like to have another kid. So I asked them to wait and to use 2 methods. Until they get treatment. She was not aware of previous Hep A or B vaccination. She has GERD, and she also has both bipolar disorder, and she's having postpartum depression, probably grief since that loss. She has a history of epilepsy, but she hasn't taken a seizure medication in a year and hasn't had a seizure in a year. She has hypertension. And she's followed by one of my colleagues, so that's good. Her medications are listed here: amitriptyline, Flonase, ibuprofen, lisinopril. Can you keep scrolling there, Elizabeth? She does take omeprazole for her GERD and Zoloft. She, by lab work, is not immune to either Hep A or B. We did start, if I recall the lab work, actually, she had positive surface antigen, but her titer was low. We did give them both vaccines while they were here. So it looks like she's been previously vaccinated to Hep B, and maybe that will boost her response, is what I'm thinking. She had an elevated BMI that's not listed here, but you can see her height and weight. Her CBC was fairly normal. PTINR, her liver enzymes were a little bit elevated. APRI was 0.4, child took her Q class A, and her MELD score was 5. Her iron studies were normal. Her vitamin D was quite low. We started her on replacement. AFP was 1.8. She's HIV negative. Her genotype was 2B, which is interesting. It's different than her partners. Her viral load was 665,000, and her fibrosis, her fibrosis score was fibrosis stage 0. So as I mentioned, I advised her to stop drinking and add another form of contraception. We added her vitamin D. We've started her on Hep A vaccine, and we'll probably recheck her Hep B surface antibody. She is scheduled for an elastogram in about a week. And so I was thinking Maverick for 8 weeks, and just wanted to make sure that there's nothing I've missed.
Thank you so much, Jennifer. Any questions for this case? If not, go ahead and unmute when you're ready. Thank you.
Hey, Jen, I'll go ahead and speak on her. Thanks a lot. You've really tackled everything. I agree with doing the elastogram. Even though her fiber test is F0, she's genotype 2, but she's got risk factors for fatty liver, alcoholic and non-alcoholic. So I think that's a good thing to do. Agree with Maverick, times 8 weeks to avoid the PPI. You hit the nail on the head. The only, I guess, caveat I'd say to that is just with the contraceptions, since we're recommending, you know, she avoid pregnancy and recommending a second form of contraception, just being conscientious about starting an ethinyl estradiol containing contraceptive method. But I will have the pharmacist speak on that because the data is suggesting you can use those just at certain doses. But I'll have Rachel or Samantha speak on those if they don't mind. But agree with your plan. Yeah, for sure.
Yeah, so this is kind of fresh-ish information. They have finally updated the package inserts, did some studies with the Mavorite and ethinyl estradiol. So the cutoff for the ethinyl estradiol was going to be 20 micrograms. So they're saying that so long as that product contains less than 20 micrograms of ethinyl estradiol, then it can be co-administered safely. If there are products that are greater than 20 at that point, then it's not recommended, and they want you to avoid it. So you could either hold it or change to a different product, whether it's a product that has less than or equal to 20 micrograms or a product that is progestin only. So you do have some options on that, but that is brand new information that they just updated with at the end. I think it was just at the end of the year last year, maybe in October or so. I can't remember exactly. So it's still newer information. So it's I've still see most people that are holding off on it, but it looks like from the data that we don't see the concerns that we saw before, which was the increase of the ALT when those were co-administered.
Nice. Okay, great. Thank you.
Thank you so much. Any other questions about that case, Jennifer, before we quickly do the
Nope,
next?
that's it.
case? Perfect. All right, I'm going to share that last case with everyone. Give me one moment, please. This is the 44-year-old male.
Yes, so this is the other half of this couple. He's a 44-year-old Caucasian male, also with Medicaid Aetna. He was also diagnosed in 2020, and he says that at that time he was also told by GI, it was just 4 years ago, that he didn't have enough in his bloodstream to treat, which what I think he meant was that his fibrosis score wasn't high enough. However, my partner who referred him to me saw him and did a FibroSure which showed cirrhosis. And so referred him to me. His risk factors are intranasal and IV drug use, starting first at age 13. Same story as the partner / wife. He's been sober from illegal drugs for 3 or 4 years, and but is drinking alcohol. And he said that he can stop and had a plan to taper over the next several weeks. He has COPD, bipolar, gout. He has had a cholecystectomy, he has scoliosis, and he does have acid reflux. He uses Tums. So his medications are Advair, amlodipine. Oh, I always forget what aripiprazole is, but he takes it. I forget the brand name. Buspirone, Cymbalta, ibuprofen, ipratropium, ProAir. We can scroll down to labs, I think. So his CBC was normal. His liver enzymes were elevated. You can see there, PTINR were normal. His APRI was 0.88. Child Turco-Q class A, MELD score 6. Iron studies were normal. I've started him on vitamin D replacement. So, so his AFP was 3.2. His HIV is non-reactive. He is genotype 3. His viral load is 6 million, and his FibroSure was had him at at cirrhosis, of stage 4, and then I did a FIB-4, which was up at the top. I think it was 1.62. I have his elastogram obviously scheduled for next week, and that will be really important information. We started him on vitamin D. His thing with the Hep A and B was similar. His Hep B surface antibody titer was low. We gave him vaccine, and we also started vaccinating him for Hep A. So we'll see. So a couple questions on him. If this is cirrhosis, which I'm assuming it is it okay to proceed with treatment prior to the ultrasound? And I was trying to remember about the duration of treatment with a viral load of 6 million. Is 8 weeks enough, or do I need to go for 12 weeks? And then assuming that his elastogram, confirms the cirrhosis, then obviously he would need continued monitoring for that and for HCC, I think with every 6 months ultrasound or elastogram. And then the iron, I had a question about the iron studies. I'm not real strong on liver stuff. And can you go back to the iron studies? I said they were normal, but they weren't. His let's see, what was really high? His TIBC was really high. And I was but his ferritin was normal or low normal, and I was confused by that. So anyway, those are my questions on this guy.
Thank you so much. Does anybody have any further questions about this case before going into the recommendations? All right, whenever you guys are ready, thank you.
Man, Jen, this couple just breaks my heart.
Oh gosh, I'm
like, my goodness, and it's just, they were so young. I mean, thank goodness they found each other. Did they help each other get sober, or have they been together a long time?
Yeah, I don't know how long they've been together, but their story was really interesting. I said to them, they got sober without any medication, and they said we did not like the life, and we wanted to get out of it, and we just decided that it would be better to get sober and have a family.
I think that's sweet. And they were both so young when they started.
Right. Yeah, it was a really pretty heartbreaking story, but anyway, they seem to be,
Yeah, it's interesting too. So we know that they didn't infect each other because their genotypes are different.
Right, exactly. I know.
Right. But I think a couple things. I think your train of thought's beautiful. He definitely is somebody that with genotype 3, we certainly are worried about cirrhosis. It seems from his fibro test that he's there. I would say, despite if he truly does have cirrhosis, we do know he's compensated. His platelets are preserved, INR is preserved. APRI is also consistent with concern for advanced fibrosis. The FIB-4 really was in that in-between cutoff. It doesn't really give us much information, but we have enough other objective information, even without the ultrasound, that yes, he's somebody we would treat as cirrhotic until proven otherwise. So I would say with that token, his AFP is normal. So I would say even, certainly he needs to have an ultrasound, but I can't think of how it would change our management if it were not completed before he initiated treatment. Now, if his AFP were very elevated, or if there was any question at all about decompensation, I'd say we absolutely need to get that first. But in his case, I think that pending ultrasound, let's go ahead and get the process started. I agree with the Maverett 3 tablets once a day with food. I think that would certainly be appropriate for him. 8 weeks is enough. So you have the right thought process with thinking about that 6 million. We think of that with Harvoni. So remember with Harvoni, which we don't talk about very often anymore, but if a patient is treatment naive and genotype 1, in not cirrhotic and not HIV positive, then if their viral load is less than 6 million, we can do Harvoni for 8 weeks. So that's where, Harvoni for 8 weeks instead of 12. So that's where that 6 million viral load comes into play. But with Mavorite and Epclusa, that degree of viremia isn't going to dictate your therapy duration.
Okay.
You'll certainly need 6-month HCC surveillance ongoing via ultrasound. And then I also would check cirrhosis labs every 6 months as well, AFP, CBC, CMP, INR. Are the iron studies consistent with cirrhosis? So really, what I would expect to see would be an elevated ferritin, more from inflammatory milieu with the alcohol and cirrhosis. But I wouldn't interpret his studies as having a correlation necessarily.
Okay, that's what was confusing to me.
Yeah, I gotcha.
Should be high.
No, other than I just looked it up, because Jen, like you, I can't ever remember them.
Oh, thank you.
I look at ferritin and iron,
Yeah,
and then
outside of ferritin. The only thing I would do, he's not anemic, but what I was saying is look at his MCV and see if it's normal. Because it should be high. If he's cirrhotic, it should be high. If it's normal, then look at his RDW and see if you have a couple divergent cell types. And it said if you do, then make sure they're not anemic. I'm wrong word, not GI bleeding. That's all it said. From isolated high TIBC. And you guys should probably defer that to Quentin. He's closer to this than I am and smarter than I am. That's what my Google just told me.
Thank you for Googling it. Clearly, I didn't Google it before I got on.
Excellent. Thank you very much. Any other comments before going to the didactic? All right, I think we're good.
Thank you
Jennifer,
so much.
Thank you very much. And thank you for the case, everyone. All right, Kaylee, did you want me to share my screen or do you want to go ahead and share yours?
I think I can go ahead and share mine. Give me just a minute though. Let me see.
And if we need to do a little more of your slides next time, we can as well. Kaylee, next session is session of cases, so we can
Sure.
always.
Oh yeah, I forgot
we
about
need
that.
to.
Well, yeah, I'll try to make it as abbreviated as I can. Let's see. All right, you guys can see, what is that? I am so goofy today.
Perfect.
Okay, let's see. Does that look good?
Looks
Everybody?
great.
You can see it. Okay. All right. I'm talking about DoxyPep today. Does anybody use DoxyPep yet, or anybody know anything about it? Because it's a fairly new concept. I can't see the chat when I have my slides up, so just you shout it out.
No worries. Yeah, you can raise your hand if you've heard about it.
So yeah, it's this is an emerging tool in bacterial STI prevention. So I'm gonna try to breeze through this, but it's a pretty cool concept. So objectives: summarize the data from recent studies exploring the use of DoxyPep to prevent bacterial STIs, and then discuss potential implications as well as concerns surrounding the implementation of DoxyPep in clinical settings. So why do we worry about, STI post-exposure prophylaxis? Why are we even considering it? So US, we're experiencing sustained increases and steep inclines of rates of sexually transmitted infections. So in the United States, 1.6 million cases of chlamydia, which is a little bit decreased since 2018, but this is 2022 surveillance. 648,056 cases of gonorrhea, which has increased since 2018, and then syphilis, an 80% increase since 2018. Also a pretty big rise in syphilis among newborns, which sucks. So almost 200% increase there as well. Anyone who has sex can get an STI, we know that, but some groups are more affected. In West Virginia, interestingly, so the number of STD cases per 100,000 residents in our state has increased by almost 200% from 2000 to 2020. So making us the 5th highest STI increase in the whole nation. So not a great thing for us. We now, have really good tools for HIV and HIV prevention, such as treatment as prevention and pre-exposure prophylaxis, but we have not had these same types of innovations for the prevention of bacterial STIs. Certainly, if these are left untreated, we have several complications that can occur. So increased risk of giving or getting HIV, long-term complications in terms of chronic pelvic or abdominal pain, infertility, pregnancy complications. So this is something we need to address. DoxyPep has really had some interest for some time now as STI targeted prevention. It's a single dose of doxycycline taken after condomless sex. There are multiple randomized control trials that support the efficacy of DoxyPep, particularly in high risk men who have sex with men and transgender women. So this strategy is offering some new promise as a widely available, plus it's an affordable option for STI prevention. So why Doxy? Why not something else? So we know that doxycycline's safe. It's well tolerated. It's very inexpensive. It's a drug we've used for decades for everything from acne to rosacea to antimicrobial suppression and certain prosthetic infections. We use it as other forms of prophylaxis. So long-term prophylaxis against malaria, Lyme, post-exposure prophylaxis. We have a very good understanding of its safety profile. We know side effects typically are GI, like heartburn and nausea, sometimes photosensitivity. But we have a very good understanding of its profile, and it already treats a number of bacterial STIs. So remember, it's first-line therapy for chlamydia treatment, and then even with syphilis, we're using it more now as first line due to the bacillin shortage. With gonorrhea, so it's not first line, and 20 to 25% of gonorrhea isolates are already doxycycline resistant in the US, but it definitely has some promise. So randomized controlled trials, there are 4. I'm going to really talk about the big 3, DoxyPep, DoxyVac, and DPEP. These were all open label, and the limitations were really short-term follow-up. So anywhere between 9 to 12 months was a follow-up for these studies. So definitely need some more long-term data, but pretty promising. So DoxyPep, this study was conducted in the US at 2 different sites, San Francisco and Seattle. So multiple sites, but 2 different cities. There were 501 participants. 327 were on PrEP. 174 of the participants had HIV or have HIV. The eligibility was for those that are men who have sex with men and transgender women who have had at least 1 male sex partner and at least 1 bacterial STI in the last 12 months. Intervention here was DoxyPep versus no DoxyPep. The primary endpoint with this study was the relative risk of STI infection, so either syphilis, gonorrhea, or chlamydia per quarter. This study period was over 12 months. The findings in this study showed that DoxyPep really significantly reduces the time to first STI by 65% per quarter. And so the breakdown by STI risk reduction. So for those that were taking PrEP, chlamydia risk reduction was 88%, and those that were those individuals who are living with HIV, it was a 74% risk reduction. So overall 81% risk reduction with chlamydia. With syphilis, 87% risk reduction for those on PrEP and 77% for those who live with HIV. And gonorrhea, it was closer to half. So 55% risk reduction with individuals, this is again per quarter, who were on PrEP and took DoxyPep, and then 57% in those who have HIV and were taking DoxyPep. They also found that, so even though the numbers were smaller with gonorrhea and chlamydia, they also found that ceftriaxone use for as treatment for gonorrhea was actually 50% less in the DoxyPep arm. So that's a pretty important benefit, because if we're able to reduce broader spectrum antimicrobial use by decreasing the amount of STIs, that would be wonderful as well. DoxyVac is was a study conducted in France that also had a large number of participants, so 502. This followed HIV negative men who have sex with men on PrEP for at least 6 months, and also was looking at individuals who were at very high risk, so had had a bacterial STI in the prior 12 months and multiple sexual partners, but no STI symptoms at baseline. This study is a little bit different in that it was a 2-to-2 factorial design. So there were 2 interventions, and individuals were randomized twice. The first intervention was DoxyPep versus no DoxyPep. And then out of those groups, there was a second randomization for individuals to receive or not receive the 4C Men B, so the meningococcal B vaccine. So some got both interventions, some had either intervention, some had neither intervention. This study was over a period of 9 months. The primary endpoint was the time to first chlamydia or syphilis infection in the DoxyPep arm. They did not look at gonorrhea as a primary endpoint with DoxyPep because of the increased prevalence of resistant gonorrhea in France. It's already high at baseline, so they hypothesized it would this intervention would not be effective. There was also an earlier study, so that 4th study I mentioned, it was part of the Ipergate trial. They did not see an effect on DoxyPep prevention or post-exposure prevention with gonorrhea reduction. They also looked at the Men B vaccine. So that role was to see if giving the Men B vaccine reduced the time to first gonorrhea infection. So 2 different arms. They found that 85% overall risk reduction over a 9-month study period. So 80% overall in syphilis, chlamydia, 90%. Risk reduction in the time to first STI with DoxyPep that was looked at each quarter. They also incidentally noted that the time to first gonorrhea infection in the DoxyPep group was reduced by 50%, which is very similar to the DoxyPep study. So they weren't primarily looking at that, but oh, by the way, we also noted this as well, which is great. And then the last study is actually the disappointing one, but this is something that is also important. So this is the DPEP study in Kenya. This study also had large numbers, so looked at 449 cis women, ages 18 to 30, who were already taking HIV PrEP. And this again was in Kenya. 18% of these women had an STI at enrollment. The intervention for this was 1-to-1, so Doxy versus no DoxyPep. They also followed this quarterly. They did gonorrhea, chlamydia, and syphilis testing. The results of this study showed an annual STI incidence of 27% during the study period. So 109 new sexually transmitted infections during the study period. 50 of those occurred for women taking DoxyPep. 59 in the standard of care arm. 78% of those STIs contracted during the study period were chlamydia. So unfortunately, there was no difference between the time to first incident or STI or incident chlamydia in either group. So why was this not effective for prevention in women? Why did this not work with cis women? And that's the question that we would love to know. A couple hypotheses are that maybe the anatomy, so maybe penetration of doxycycline and endocervical tissue might differ from urethral or rectal or pharyngeal tissue. There are some small pharmacokinetic studies that look at drug levels, and it does appear that doxy reaches therapeutic levels in all sites. So that may not be the reason, but we don't really know the way that these pathogens would adhere to these tissues. So that could still be a possibility. Another thing that we could consider is, so this again was a study in Kenya, so potentially maybe the type and frequency of STI exposures in the study group might differ from because of where the study was conducted. We also wonder, you know, well, were these women, did they all have resistant STIs? And that's why there was a different outcome. But to date, we really have not seen any, so no cases of resistant chlamydia globally, but there are high rates of gonorrhea. The big one I would say is adherence. So these women, they reported high adherence. If you remember from when we've done our PrEP talks in the past, the initial PrEP trials in cis women also showed very disappointing results. And now the more recent studies have shown it is effective because those early studies really were based on, dependent on reduced adherence. So they had poor outcomes with those that were not adherent. With this study, you know, it was really a trial designed to maximize adherence. So these women were already taking HIV PrEP daily. They already were very high risk. So a third of the women in this study engaged in transactional sex, had multiple sex partners, and none of them contracted HIV. So you would assume that if they're already used to taking HIV PrEP consistently and have good adherence, that they would also have similar adherence with DoxyPep, and they did report high adherence as well. However, more recently, it was presented at CROI this past year. They did conduct doxy hair testing and found that 44% of the women assigned to DoxyPep arm, they never had detectable doxycycline at all. So despite being randomized and also reporting high adherence, they were not taking at the rates that were reported. And I guess with that, I have to stop because I was going to talk about what to do and how we prescribe it, but I'll save that for next time.
That sounds great. Thank you so much, Kaylee. We can definitely do that next time.
Yeah.
Next time we'll just tackle that at the beginning and then go into our cases.
Sure.
All right,
Thank you,
everyone.
Kaylee.
Thank you, guys.
Have a great weekend. We'll just go ahead and say goodbye. Thank you so much.
Thank you all very much.